we have this workshop for the surveillance for invasive pneumococcal disease, recommendations for implementation. So I'd like to invite Dr. Jayasiran to sit with Dr. Nick Khairuddin, and the floor is yours for you to actually discuss on how shall we actually do this together. You've got the whole crowd here. Let's see how shall we move forward. Thank you.
I'll just give an overview in terms of what are we do, what data do we have at the moment, and in terms of what are things that we can do, suggestion on some of the recommendations for the surveillance program that we can do. And I think Dr. Jaya will go into more details regarding the sort of a study that we can do to start off this program. Okay, so I'll skip some of the presentations because I think for the more than half a day already, you probably heard the same things over and over again. Okay, so this is the thing that we know, that vaccines are, preventable diseases are still very important, and that we know that still about 500,000 children are dying of pneumococcal disease in the world at the moment. Okay, we have to realize this is the reasons why we want to start vaccinations in the country. The one that came in with severe infections, with mortality, and also with severe morbidity. So, but also we know that pneumococcal disease, although we are able to show data in terms of invasive pneumococcal disease, but there's still a huge part of as well in terms of non-invasive pneumococcal, and that's why we are trying to stress the point that although we have the figures that we feel is fairly low for invasive pneumococcal disease, but I think on the ground level we are seeing so many children with that, and I think pneumonia would be the main burden in the hospital settings, and otitis media maybe in the hospital and also in the clinic kesihatan. So remember, we are looking at the red part only, the small parts, but actually for the community is a huge burden of disease in terms of pneumonia and otitis media that we have to, where the benefits of vaccination would certainly be proven there. Okay, so for the surveillance of pneumococcal disease, I skipped many of this slide. I think we know, I've just skipped what is surveillance all about. And I just pick from the WHO Vaccine Preventable Disease Surveillance Standards 2018, certain things that we have to have in our minds when we're discussing how to do surveillance. First, like for example, of whether the objective can be met with an existing integrated surveillance platform with a minimal increase in resources, or is it disease-specific surveillance required? Is there sufficient technical capacity, including epidemiological staff and lab infrastructures? Is there adequate funding and other resources, which seems to be the main problem whenever we want to do any surveillance program? And other things that have been emphasis in terms of doing VPD surveillance is that the issues regarding linking lab and clinical-based data, which has been discussed and has been elucidated before. I think integration with existing surveillance system has clear advantage, and at the heart of successful VPD surveillance lies high-quality data, including linkage between lab and epidemiologic data. So that's the area where the emphasis is for us when we want to do surveillance for VPD. So I think the WHO mentioned some of the objectives of pneumococcal surveillance. I think there's nothing new in terms of we want to know quantify the disease burden, disease serotypes distributions, evaluate vaccine impact, and monitor antimicrobial resistance, and maybe also probably smaller in the sense of outbreaks, identify the pneumococcal outbreaks, and also later on when we started the program of implementing the immunization program and looking at the gaps and things that will to change or the policy of vaccinations if needed. So I think that's sort of a standard one. So I just quickly go through what is happening in terms of surveillance. I think it's, as I mentioned before, that we are there's already 142 countries out of 194 countries that has implemented this. So we can learn from the experience from many other countries before. US has been one that has started the surveillance program, the earlier ones more than nearly 20 years ago. And they do a nationwide mandatory notification, initially starting with age less than 5, later on become all age group. And they notify within 1 week, and they collect certain informations and data. I think many of the United Kingdom also is a notifiable disease. And all isolates sent to the National Reference Lab for serotyping, and all under 5 IPD cases will be followed up by public health. The Australia is notifiable for quite a while already. They funded 4 labs to perform serotyping, and this is overseen by a special group, which is the Enhanced Invasive Pneumococcal Disease Surveillance Working Group, which is under the Communicable Disease Network Australia. And the same thing is in New Zealand as well. It's a notifiable disease, and they have a group to look at it. Okay, we heard about South Africa, so I don't have to mention about it. We heard about Taiwan from Dr. Lu, Professor Lu this morning. It's also notifiable disease, and I think seems Taiwan has not much of a problem in terms of implementing notifiable as notifiable disease. Okay, WHO recommendations in the position paper and also the VPD surveillance standard, they mentioned that surveillance should be begin at least 1 to 2 years prior to PCV introductions and continue indefinitely, or at least 5 years after introductions. However, lack of comprehensive surveillance system should not be impediment for PCV introductions. And the sort of surveillance that WHO recommended is quite 2 types. One where it is minimal, whether you look at the meningitis cases also only at the hospital level, whether all the case meningitis is investigated for BD, or enhanced surveillance where it is more like at the either expanded sentinel hospital surveillance, including meningitis, pneumonia, and sepsis, or population-based surveillance for IPD like what GEMS as South Africa is doing. Okay. So when we look at what is the current status of pneumococcal surveillance, I think Dr. Fairuz has mentioned this. I think we do have some surveillance program going on for pneumococcal, mainly lab-based and based on the national surveillance of antimicrobial resistance. We got samples from government labs mainly, and then IPD pneumococcal isolates, which is invasive one, was participating labs are encouraged. I think I suppose the word is encouraged to be sent to IMR for serotyping. Then the data are also entered into HUNET software by local lab staff and sent to IMR at regular intervals. Then data are analyzed and annually reported as part of National Antimicrobial Resistance Report. This is, has been mentioned before, the latest report was the 2017. And we look at that, during this 2017, there was about 42 labs out of we have about 140 plus probably hospital in the country. So 42 labs contributing the data. So there was about 39 from the public hospital, and there's also 2 from universities, which is UKM and also UMMC. So this would represent probably 30-40% of the numbers of labs reporting. So this is an area also whether we are the numbers of labs contributing data through HUNET software will be increased over the years to cover more and more places. So what are issues with current surveillance? Well, we have discussed many of these: low isolation yield, whether prior antibiotic exposure, culture techniques also. It's not really, I do not know whether it's standardized or not. I know that where the culture media has been, when, for example, in our hospital in 2017, we were able only to culture about 2 IPD. And at that time, we were using in-house culture media, where because of this difficulty of getting some of the sheep blood, or basically they're using human blood, and this reduced the yield of culture. But by the time last year, when we used the commercialized one, we were able to culture about 10 samples. So there's the way it has been done at the local lab is also need to be looked at. Okay. PCR, I think it's been mentioned. I think this is something, an area where not being used in most hospitals, not being used, and that will reduce the yield in terms of detections. And I believe many of the, especially states hospital, actually has the facility, has the machine there, but the problems usually is to get the primer or the reagents to maintain this program. So they do have and they do run for certain tests for certain organisms, but usually probably is funding usually to get to buy primers to do for IPD, and this is something that I think we should be focusing as well. Not all labs participate in transferring data. I mentioned not all isolates are sent to IMR, It depends on local labs whether they are committed to do that. It depends on the microbiologists whether they're happy to send or not. Many isolates die on transfer, minimal clinical data available for analysis, and no detailed data analysis centrally. Okay, so some of my suggestions in general sense, many of things has been mentioned here. Okay, first is nationwide mandatory notifications. I will discuss each one of these briefly after this. Enhance IPD surveillance at sentinel sites, improving appropriate specimen collections, strengthening the lab diagnostic capacity, improving data management, getting the data together between the lab and the clinical data, and also to do the other parts of study. So I just go briefly. I think we have discussed about mandatory notification. I think in terms of in the parts of clinicians, I think we are pediatricians. I think we are okay, happy that if we can do for notifications. The question is whether notification is for IPD under 5 or notification of IPD all age group. It depends on really. I think if the best is to actually do notification for all IPDs, because this is for long term. So we will want to look at notifications at older age group as well. So that's important. But it is really in terms of burden of work to the public health, the district office, and so on. Because I could consider, if we look at the figures that we have, we say if the rate of under 5 IPD in Malaysia is about 10 or 20, around 10 or 20. So we could expect around probably about 300 to 500 cases of IPD throughout the country. Okay? So if we say it's throughout age group, we probably get about 2,000 notifications. So that's something that have to be discussed whether that is something that can be done or not. Okay, I think case definition is quite clear. I won't discuss because there's a very standard notification way. Notify within a week is been the standard way, and notification by notification form or CDCIS e-notification system. Okay. This is the form. Usually we tick this. There's already 30 plus diseases inside there, but we do get some information from this form. Although we say it's not a complete information, but we will have information on age, gender, locality, date of onset, and type of specimen and test done. So there are some data that we will be able to collect from the mandatory notification. Okay. Right, so this might be, if we are going for mandatory notification, the reporting system, the flow chart for reporting system, okay? The usual way from the case of IPD, from the reporting clinicians, district office, state health, and the bahagian kawalan penyakit. And the results, we have that through the microbiology lab, from the hospital and so on, and through the IMR in terms of results. So, so these are possible when we want to implement a notification. We could finalize this more or edit this later on. Okay. Second thing, I think, is sentinel site surveillance. I think we should also be embarking on this. Okay, that we need the consistently high quality surveillance data, and this we could be able to get from having a targeted sites, few selected sites where we can really look at the lab data and also the clinical data as well. And I think this is probably the planning was that we would do it as part of a research program, research project that will be incorporating some of the centers in Malaysia, and that will be discussed later by Dr. Jaya. Okay, we have discussed this, and it's important to strengthen the diagnostic capacity to get the diagnosis. There's two components. One is that basically the frontliners and the ensuring appropriate clinical samples taken by doctors in hospitals and clinic. Okay. We need to look at this again. What are the actual practice now in emergency departments, in our hospital? What tests do we do for pneumonia? Not all hospitals do cultures for pneumonia. They may not do it. So this is things that we have to also look at so that we can increase in terms of number of cultures being sent for this. Second part is the laboratory part. I think this is an essential component of it. Local referral lab capacity to isolate and identify IPDs. And this usually funding, I think funding, having create SOPs, and also training of the staffs in the labs, including culture bottles, culture media, penicillin testing, antigen detections. I think I would propose that this is probably, if we cannot do it on all sites, but for the sentinel sites, that we have enhanced detections of IPDs by having antigen testing incorporated as part of their diagnostic tools. Okay, that we have discussed transport and also serotyping of all isolates for cases less than 5 years or all age group, depending on the capacity of the labs. Data management system, we know the problem now is that there's no comprehensive integrated data management for IPD. And we know the data, that what we have now is HUNET, contains mainly data on isolates with minimal clinical information. But there's not that many labs at the moment. It's not more than half at the moment is contributing data through the HUNET system. So that need to be looked at as well. So obviously we need a new sort of collecting database to get to integrate the clinical and laboratory data. And so probably the study group would be able to create this, which can be the basis for the future surveillance program that run under the Bahagian Kawalan Penyakit. Okay, and lastly, I think the other surveillance carriage study is also important. We look at the carriage studies, obviously, is important, and this can be done in parallel with that. I think this is not the priority for us to do at the moment, but I understand that universities are happy to continue as a collaborative studies to do nasopharyngeal studies to look at the serotype distributions in the community. So that's sort of overall plan, and I put in some thoughts, the final slides here, just to put in some timeline here, so that we could discuss this further, so whether this is feasible or not. Okay, so this is something that can be discussed afterwards. Okay, so I think that's all. Thank you very much.
We've been sitting here the whole day talking about pneumococcus. Something has to come out from today. And I think I will go through what we are suggesting for the surveillance, and we have to put this into place at least as early as possible before pneumococcal vaccine actually gets implemented itself. So let's go through the slides. I think we've seen lots of it, most of these issues. Just look at the words that have been underlined. So why the surveillance? We want to look at effectiveness. We want to see what changes. The bugs are not going to stay quiet as we introduce a vaccine. They are going to change. We also need data to help our health planners decide what they're going to do now and what they're going to do in the future. High-risk populations, and most importantly also archiving the disease activity. This is important in the age of anti-vaccines, vaccinous pressures. I think we will need to archive all this information. So specifically in pneumococcal surveillance, we will look at these 5 areas: burden, spectrum of disease, clinical outcome, serotype, antibiotic resistance, and we will look at this in the context of age and geographical distribution. Okay. So again, as we heard about this, we are lacking in a comprehensive surveillance system linking both clinical and laboratory data, and we don't have standardized reports. In most countries where IPD has been, surveillance reports come out every year looking at how they are doing with the vaccine program itself. And but we have lots of reports on serotype and disease burden, but it's difficult to link all of them in a temporal way to have a trend. Okay, and I think Dr. Fairuz has gone through this particular study itself. This is one of the latest studies that's come out from IMR, and basically it's probably one of the most comprehensive serotype data that's come out. And I'd like to attract your attention to the number of specimens. And so we had 530 specimens for children less than 5 years of age, 245 were invasive. So it worked out to be an average of 61 serotypes per year. Okay, so that's the number they've got. If we look at burden, there are many different studies. Unfortunately, the case definition, each of them varies and it's difficult to compare them. So with all those things, we need to have a system in place. So our suggestion is that we do this surveillance as part of a research proposal. The sentinel surveillance of these particular sites, basically MOH specialist hospitals, KL, and also the university hospitals. So what's really left out in this group is the private hospitals for logistic reasons. But in what Nick was saying as part of notification, the notification can go on to all hospitals. This Sentinel survey will have the extra input or basically the lab data being linked to the clinical data in a very clear methodology so that we will be able to interpret the results at the end of it. Case definitions, I think, as per in most other studies itself, is basically isolation of strep pneumonia from normally sterile sites. As you remember, I think, and it's been mentioned by speakers, this is just a surrogate marker of the whole IPD, whole pneumococcal problem. It's in the slide that Nick showed. It is only the top part of the pyramid itself, the red part. The rest of the whole problem of pneumococcal is there in the community. So whatever we find as a number, it's basically just a surrogate marker of the overall problem. So what's the objectives? Just to describe the pattern of IPD among children less than 5 years in Malaysia using a sentinel survey. So again, in the specific objectives, you see those words underlined, basically burden, type, mortality, serotype, and resistance. But we need to see the trend. So it has to be done over a period, okay? And the clinical data that we are going to collect, this is the minimal data. We can discuss whether we need to collect more data than this or not. It's basically which hospital it comes from, age of the child, race, nationality, PCV status, type of IPD, and outcome. So this needs to be linked to the microbiology data, basically just the MIC, which most times is performed by the local lab itself, and the serotyping data from IMR. So stakeholders, who are the stakeholders? So one of the problems organizing this is that there are quite a few different stakeholders in this surveillance program. You have the pediatricians, hospital microbiologists from IMR, and here I'm proposing that CRC take the lead in the hospitals to start looking at data completion, and CRC EPO become the lead CRC to collect all the data for the surveillance program. And not to forget, disease control division, very important. They will have to help us decide population data, because if you want to work, one of the problems at doing a surveillance, sentinel surveillance, is working out what is the population that you are dealing with. And you have to have some form of calculation to decide what is the denominator that you're going to use, and that will help you decide the incidence. Otherwise, you will just have only a number. And they will also have to look at the reporting system, whether suggested by Nick, whether that will be the start of the reporting system, because long term, again, disease control is going to be the one that is going to be holding the fort in this particular surveillance itself. So data basically manual, but if we can afford a web-based system, that will be very good. But I understand that's going to be very expensive, so manual might still be the way to go. Data capture from primary site, coordinated by CRC at your own hospital, and data sent to the lead CRC, which is HRPB EPO. These are some timelines which I've suggested. Basically, we would like to have this going by the early part of January 2020. So we have, protocol review. We have written a protocol. We're happy to share that protocol and see whether we can strengthen the protocol. Budget planning, grant application, MREC, investigators meeting, trial run, and start of the surveillance itself. duration of study. So we can start in 220, but when are we going to end? It will also depend on when the vaccine is going to be implemented, vaccine program is going to be implemented. So my suggestion is 224, maybe it may go on to 225, okay? So what do we hope to get from this particular study itself? Sorry, before that, ethics, we're going to apply for ethics waiver because there's no personal data leaving the primary site, no extra investigations and procedures to be done. No? Costing and funding, there will be costing. There will be investigative meetings, we may need some extra research assistance, and if the reporting system is going to be on the website, if you're not going to use whatever we have now, then there will be an extra costing, otherwise we go manual. And funding of serotype testing, again, there might be an increase in the number of testing to be done, and the cost there might be a costing issue with that. So where are we going to get the funding for this? We have two choices. One is Ministry of Health, NIH grant, or we might have to do this as a hybrid study, and the funding may come from a pharma. That means the protocol comes from us, funding comes from pharma, and that will be considered as a hybrid study. And this is something that needs to be discussed, which direction we're going to go with the funding itself. So what do we hope to have at the end of the day? So we need to have an interim report, again with all those elements that we want to report on. But the most important thing, that it must be trends. So it has to be interim report yearly, and then as the year progresses, it will turn to become trends. And so we hope that is the way that this will turn out, and we need these trends to again see what is happening before vaccine implementation, during the vaccine implementation, and for a couple of years after the vaccine has been implemented. What are our challenges? I think we have touched on some of these issues. Population data is going to be important because it's a sentinel survey. We have to have a standardized way of deciding what the denominator is going to be. We have discussed about the viability of specimens, monitoring and evaluation. So you want to have good data, there has to be a system of monitoring and evaluation. As one of the points that Susan mentioned during her slides was that they are able to access the system and double check whether all the specimens have come to the central lab or not. So that's a good way of monitoring and evaluating that, to make sure that we have all the specimens coming in. So again, the challenges is merging and strengthening the existing system so that this surveillance system will continue in the future itself. Okay? Now, while we're talking about the under 5, it's tantalizing to look at, again, slightly a broader picture of what IPD is, or the pneumococcal problem is for the population. This is looking at what happens to rates of invasive pneumococcal disease in US adults after introduction of the vaccine. And we have seen a major drop. So this is, again, if we can afford it, we should incorporate this particular data into the surveillance system so that we can show that money that's been spent for the vaccine program has lots of different outcomes. This is the indirect outcomes that we have. So again, if we can afford it, we should try to look at the burden in the sentinel sites across all the ages. But again, this will depend on the planning of the protocol itself and the funding we're going to receive. One last thing, I think again, Nick has mentioned about the nasopharyngeal carriage. I do not propose that we look at this point in time as part of this particular study. This helps be done parallel because it has importance, but I think it is out of the context of this particular study itself. So, what I would like to suggest is, this is supposed to be a workshop, so there will be a lot of discussions. So we need to name the stakeholders. Who are the pediatricians who will lead that group? Who are the microbiologists in hospital who will lead that group? The microbiologists from IMR leading group, and finally CDC itself. We need to agree on a timeline. We need to work on the protocol, and we need to make decisions on financing. And that's my last slide. And that's your summary. Thank you.
You got the details on the clinical aspect. Then the labs need to actually come up with the protocols that you're going to utilize, and also the budget issues as well. And then after that, you need to develop the CRF. Then you got to actually have the consent. Then you got to have the patient information, in both English and Malay, for you to actually give out to the participants. Then after that, let's see whether can we not have consent, yeah?
So I think we
can.
We are hoping that we will get a waiver because
probably you can, because this is secondary.
All procedures are standard procedures.
Yes.
And we're not doing anything extra.
Nothing extra, yeah. So, okay. I think probably this is non-interventional. You can try. But sometimes MRC, because recently when we're doing the pertussis thing, we got consent. But that one, because we have the maternal blood to take, so that's why it is something extra that we do. I think probably this one we can try to get a waiver for consent, yeah? I think that's almost ready. So we just need to actually bring all of these components together and put it in a protocol and decide. As for the grants, you can probably try the NIH grant, but if you are up to it, you can probably get grants, compete for the grant. Many of these pharma, they've got their grants whereby it is industry, investigator initiated, then they can actually have the hybrid grant. Then you can have CRM to actually manage the finances. Yes, everything is above board. So that's one of the options. The protocol development is actually the most important thing than getting the MREC and so on and so forth.
So one of the things that we also need to decide is the sentinel sites. I just left it there as MOH specialist hospitals. So it's important to decide how many sentinel sites we're going to have, because we will need to have a critical number of samples coming in. And in that IMR study, just a back calculation with 52 hospitals that were involved, they had an average about 60 samples a year. We could, improve that particular number by, making sure that every sample gets sent, and maybe if we improve the viability of the samples during transport, we could boost the number. But if we take too small a number of sentinel sites, I worry that we may not get a critical number of samples coming in for the year. So my suggestion is every state hospital has to be in. Every university hospital will be invited. HKL will be in. And then we have to decide in your own state, big district specialist hospitals should also come on board. So that will be one of the things that we need to decide for the number of sentinel sites. So that can be decided by the pediatrician group, and they can decide in their state who are the other district specialist hospitals that will be involved.
Yeah, I think once you have developed the protocol, then we can probably, email this in our pediatricians group. And then this coming July, when we have the pediatricians meeting, then we can actually finalize the sites and get commitment of the principal investigator. And at the same time, we need to actually also get the, support of the microbiologists. So I think they're going to actually meet up for the pertussis study. So taking that opportunity, they can also deliberate on the protocol. If you could probably email the protocol to, the clinical microbiologist who's going to be there, as well as the IMR clinical microbiologist, then probably they can look at the protocol and provide some more details with regards to the methodology that they're going to use. And at the same time, you can probably start thinking about the budget aspects of it. How much do you need to actually allocate for the budget, and what kind of things do you require? The labs, of course, they've got a lot of reagents and consumables, but the clinical side, you need to also consider the kind of things that you require in terms of some consumables you need to buy, if there's any. But also the case report forms. If you're going to do it online, so you need to actually have some form of database services to what do you call it, hire or as a service, or can it be a traditional way of just using paper? So that's another option, cheaper, and so on and so forth. You still need to actually consider the statistical analysis component as well as the publication and whatever. Do you need people to factor all those in? Do you need to have outsource the statistical analysis, so on and so forth? And also, if you want to actually consider having a CRO to actually look into the conduct of the study so that it is standardized across the Sentinel sites, because the CRO would then look at how you collect data in terms of the source document and in terms of the CRF, is it done properly, and with regards to all the other conduct of the study, is it as per protocol, as per GCP, and so on and so forth. And you also need to consider who is going to actually communicate with the MREC, giving them regular updates on what's happening with your study. And finally, whether would you need to extend the study, and on study closure, who would communicate with the MREC or with regards to all those regulatory requirements. Yeah.
So that's where the CRCs come in, because we have worked closely with them in EPO itself, and they know the steps to be taken, and so that's why I suggested that CRC EPO take the lead to help organize a lot of these steps are required.
Okay, that sounds good. Yeah. So yeah.
Can I just ask something? This is going to look at IPDs, right? So why are you not including the private hospitals? I mean, we still do see cases, and those cases are so few and far between. I mean, why do you want to keep it exclusively in Kementerian Kesihatan hospitals?
Well, we can. Not a problem.
I think it's not a problem. I think if you buy into the protocol, then once you're locked in, I think it shouldn't be a problem. My initial suggestion was for logistic reasons. We are familiar with contacts with the government hospitals, but I think if any other hospital is keen to join follow the protocol, then I think we're quite happy for them to join too. But the commitment has to be there, because once you're on, then it has to go on year after year, so that we don't change the denominator halfway through the study itself.
But we need numbers, when we decide on Sentinel sites. The Sentinel site must actually commit on a number. Let's say, for instance, if I'm doing a study, then I would tell the sponsors, okay, I can probably provide 10 cases or 20 cases a year. So that makes a difference in terms of, because why? If we are going to actually employ CROs to go to the sites, so the CROs is going to actually do site initiation visit. So that's cost involved. And then if they're going to actually have monitoring visits, so if you are only going to have one, sample per month, that kind of thing, so it is not cost effective. So that's why when you conduct a lot of studies, we do choose sites with regards to what is the number of patients that they are going to bring. But if your center is seeing a lot of cases, then fine, we've got no issues with that.
No, that's not my contention. Is this? You don't see that many invasive pneumococcal disease anyway. So when you have one, it's a big deal. And I think for any hospital, it's a big deal. If we can hype it up so that anybody who sees an invasive pneumococcal disease will know what to do. And if you give us the protocol, what to do, where to send the specimens, how to send the specimens and all that. And then, I mean, after all, at the moment, we are also sending the specimens. And we also send it to IMR. I mean, I send it to IMR. Some people send it to a private lab. But, I understand what you mean by Sentinel sites, but that's okay if you're going to do just a specific thing. But you're going to do a surveillance, which is going to be for forever. What you want is to inculcate this culture in everybody that if you have a case, you send it. you know, and not just elite sentinel sites only. Then the rest of us will feel alienated and will feel out of the picture, and we won't be, even though we have cases, we will probably just send it and we won't even tell you. So the thing is to get buy-in from people and tell them, look, this is happening. We have a problem. We're going to introduce the vaccine. So help us out. I mean, I can easily get to the private pediatricians through the MPA, and then, you know, you've got that network MPA which links everybody together. And I think you should move. I mean, you're okay to do the in sentinel site, but, you know, to me, this should be a total paradigm mind shift. That means you work now, you have a case, you have to get the specimen, and you have to send the specimen to a specific lab. The labs have to up the game a bit, you know, and then start expanding the labs, and then become more responsible for the specimens, and then give us feedback. We send the specimens, we don't get a feedback. So, you know, it becomes like, yeah, what's the problem? What's the issue? Why should you send to them, you know? 3 months I see the result, the patient's already home. So, you know, I think we need to actually look at it from a different view, rather than, I understand Kementerian Kesihatan sentinel sites. We did that for HIB, I know, before we introduced the HIB vaccine for 5 sites. But this one, maybe, you know, those are my thoughts. I mean, because I don't want to be excluded. I feel the private people.
I hear you. I think I hear you. But there's 2 issues here. You know, I mean, one is doing a proper study as per GCP, as per MREC, so on and so forth. It is impossible for us to actually include every hospital. Put it that way. I mean, universal data collection is actually ideal, but it is not feasible. Just put it that way. It is not enough. So we can actually run this thing in parallel. One is looking at the study as per protocol, as per what is actually being approved by the MREC. So identifying the, you know, principal investigators, so on and so forth. So that's very laborious and very, you know, data driven kind of thing. It is very meticulous and difficult to do. But at the same time, we are also going to actually blast to everybody that they can also send in samples. So there will be these sites which is actually going to be decided. Those are the sites that are going to be looked into in more detail as per protocol. But the other sites we're going to actually have the same protocol, so they can send via the normal channel and process to actually have all the tests done as per protocol. But they wouldn't be included in the final thing. I think probably we are going to probably allow that to happen as well. Of course, all cases is the experience of people doing it elsewhere is not 100% coverage everywhere. When we are doing things, I think if you want to do it in a meticulous manner as per protocol, I don't think we can include all centers. But point taken, I think we can still have samples coming in from all of the other places with invasive pneumococcal disease, and those samples are going to be processed in a standard manner. No problem. I think that's not an issue at all. Yeah, maybe Susan want to add something to that?
Hi. How easy is it for you to get population denominator data for, you know, if you choose your sentinel hospitals, do you know what the drainage population is for each of the hospitals? Or how are you going to figure that out?
I mean,
because that's the challenge of sentinel
So
surveillance.
that's a major challenge. I was involved in another study that we had the same debate how to decide what the denominator was. So one way is to have some estimate about the burden of IPD in the hospitals around that region outside the sentinel site. Then you compare these two, and then you have the actual population of that particular area, and then but you proportionate what actually comes to this particular sentinel site versus non-sentinel site. So that particular study that was involved, I was involved with, actually had to do with a condition that only comes to an ICU, so pediatric ICU. And so because the other hospitals do not manage pediatric ICU patients, so we had to have some form of But it is an estimate. I don't think we have an exact number. But it is a way of trying to look at the disease burden in that particular sentinel site versus non-sentinel sites, and then you divide that among the population of that region.
One question. What's the purpose of doing this to know the incidence? Because the denominator is difficult. I mean, your denominator is what? Per population, per kids under 5, per pneumonia cases, you know? I don't know how you're going to do a denominator. I mean, we have problems with even our own data. WHO is questioning what's our denominator as well. So, you know.
So if we cannot come down to a number for the denominator, then it will be just number of cases only. We won't be able to work out the incidence. So we have to try to work out that number. If we can't work out the number, and each region will be different. I mean, if you take KL, then it's going to be really difficult to decide what the denominator is compared to another place where if your sentinel site is the only main hospital, then it's much easier to decide what the denominator is. So it's a challenge, and if we can't decide what the denominator is, then finally you are going to left with just number of cases of IPD.
So that is why I think the clinical epidemiologists would be very important here, because they can probably advise us on how to actually go about when you are trying to actually work out the incidence and prevalence and so on and so forth. But as you say, I mean, the worst case scenario, we are just going to actually describe what are the cases we see, and I mean, we may not have the incidence, data. But I'm sure the clinical epidemiologists have got more experience on how to come up with some solution to this statistical issue. I think they've done some surveillance on a lot of other diseases. I think they do not do universal sampling. They have come up to sentinel sites. We can probably seek their advice on how they go about in deciding on the denominator for the states as well as the national, the numbers. That can be done, yeah. But I think this is the start, so that we have a protocol, and then we can actually identify people who are going to be willing to actually provide the data, and we are going to actually get some funding. And as we were discussing, once we have identified what are the necessary steps that is required for us to run the surveillance program, then after the budget comes in, then all of these financial or resource issues can be taken up by the budget that we are going to receive. Then after that onwards, then it will be nationwide, and hopefully we can actually provide yearly annual updates on what's happening with regards to the pneumococcal surveillance in the country. That will be I think that will be a good because we've never done such surveillance for vaccine preventable. We've not done. Yeah, so it's a start. So this is actually something which is expensive. We want to make sure that we are doing the proper thing. Yes.
Do you have any guidelines on how to investigate cases of suspected invasive pneumococcal disease or pediatric septicemia or meningitis, that you can, it would be a good time to reinforce something like that with the clinicians so that adequate specimens are taken, just to get a bigger pool?
Yeah, I think I mentioned that something that we need to look at is the way the practice at in the frontliners in the hospitals or the emergency departments. What are they doing when they are facing with a child with fever or suspicious of pneumococcal, for example? And there's no real guidelines at the moment. We have a general guidelines for pediatric protocols, for example, in terms of pneumonia, and meningitis as well, and sepsis. So that's the three areas that we do have a general guidelines, but it's not a detailed guidelines and not specifically looking at pneumococcal per se. So I do agree that this is something that we have to look at to see whether something or some sort of a standardized way of assessment of a child when a sick child comes to the hospital, that so that it has been done sort of uniformly throughout the states or the hospitals in the states. So it is something that we probably have to look at as well. Yes.
Okay. Any more comments, suggestion? So we are ready. Okay, I think. Any last words? Nick? That's it? Jason? Nothing?
Maybe just to say that I think we've been maybe working in silo. I mean, we pediatricians have been working in a certain silo, the lab has been working in a certain silo, and maybe even disease control. And so maybe that's the reason why we haven't had a comprehensive surveillance program
or report, yeah?
Report. And so I think it's time for us to put our resources together and be on the same platform and start this thing going, and hopefully that will be the future for surveillance program for IPD itself.
Yes, I couldn't agree more with Dr. Jayasilan. I think it's been a long day. We've certainly actually gone through a lot of the aspects, and I'm very thankful for the organizers and for MPA for bringing us together to actually deliberate on this very important aspect. I think it's very timely for us to have this, and we are quite clear. It is just not talk and listen, but we've discussed and we deliberated and shared our thoughts, our passion, and whatever. And we look forward to actually working together. As what was mentioned, we tend to actually work in silos, but not anymore. As we move ahead, I think we are, at least for pneumococcal, we demonstrated that we can actually come together. And then we are going to actually have very clear deliverables, something that we are going to actually work on, and we're going to probably, have a protocol ready and have things in place before the money comes for us to actually implement the vaccination program, in the, I hope, in the very, very near future. Certainly, I'm looking forward to the next budget and listen to our finance minister said, for the year 2020, we have allocated 160 million ringgit to implement the National Pneumococcal Conjugate Vaccination Program and deliver on our manifesto. I hope so. Next year it's going to happen. I think to wrap up the event, I would like to thank Dr. Nick Khairuddin as well as Dr. Jayasilan for for conducting that session.